So you heard from the two previous speakers, and you actually see a lot of the same slides here. But I would define our current era of treatment of CLL as a targeted therapy era. What we've seen evolve over the last 5 decades is transition from alkylating agents to purine analogs and combinations, and then the 2000s were really the era of chemoimmunotherapy. And now, with a better understanding of the biology of CLL and lymphocytes, we now have what I'm phrasing as the targeted therapy era. Monoclonal antibodies like obinutuzumab, the B-cell receptor pathway inhibitors, ibrutinib, BCL2 pathway inhibitors like venetoclax, and even gene therapy, and we'll touch on all of these. So to go back, what seems like decades ago, but is only 10 years ago, the German CLL study and genetic analysis of that had shown that 17p did not respond to chemoimmunotherapy, and this is overall survival. If you draw the curve out, that's 18 months. So patients a decade ago who failed FCR had an overall survival of only 18 months. The depth of the remission was the key, and minimal residual disease greater than 4 log reduction, those patients seemed to do well, and those patients with a 2 log or less reduction did poorly, and this is the cumulative survival. Now what's really interesting is all the novel therapies that my colleagues have been talking about, despite their great effects, none of them achieved greater than 2 log reduction in initial clinical trials. So our understanding of the B-cell receptor pathway and its importance in CLL has really changed and allowed us to start developing these targeted therapies. And you can see here the B-cell receptor is constitutively activated in CLL, and that key components of that pathway which tell that cell to divide and make more copies, particularly Bruton's tyrosine kinase, phospholipase C, gamma, and PI3 kinase have all become central targets for these new oral inhibitors. And they shut off the ability of that cell to go on and make a new progeny. So what you saw earlier in 3 different slides was that these new targeted therapies all have great effect. And if you can see here, these are all progression-free survivals. And you can see that even in high-risk patients, which a lot of these studies contain, most of these patients had already failed FCR, that we can see that the progression-free survival greatly exceeds that 18-month overall survival. So we saw this slide earlier, the 5-year experience from Susan O'Brien in the pharmacyclics studies. But again, 17p deleted patients at the bottom of the curve, blue curve, do poorly for both progression-free survival and overall survival, roughly 26 months. In 11q patients, roughly 38 months. And complex cytogenetics is being clearly impacting how these patients do on these new targeted therapies. Upfront therapy as a single agent does better than using it in relapse refractory settings. And here we have the slide for ibrutinib. And the 5-year estimated progression-free survival upfront for 17p deleted patients is 74% from the NIH study. From Weissner's group, and the overall survivals are very, very good, and that compares to that 18 months after FCR. So how do we get to the resistance? My colleagues have already laid groundwork on this. The most common causes of resistance are mutations in the actual genes that are involved, BTK, and the PLC gamma 2. About 85 to 90% of all the patients will have that mutations. Clonal evolution is occurring in these patients as well. And we will see that Richter's transformation also is involved. Interestingly, BTK and PLC gamma mutations are infrequent here. My colleagues mentioned that Notch1 mutations seem to increase this risk. So we saw this slide earlier that Richter's transformation, it seems to occur earlier, and CLL progression is later. Other events are the patients coming off of the treatment because of intolerance. So what about Richter's? If one looks here in the box that the incidence in these clinical trials, it seems to increase as we do more of these sequential treatments. Most of the patients in the bottom here in the 10 to 16% incidence range were in the venetoclax trials, and that number seemed to be lower earlier on. It seems that increasing clonal evolution and new mutations may impact the incidence of Richter's as we move along. The other thing that I think is important to point out, how we differentiate persistent or recurrent CLL versus patients who have Richter's transformation, historically after chemoimmunotherapy trials, was based on PET-CT scan. And I think there's several recent papers, and Anthony Motto from Sloan Kettering now presented interesting data at ASH this year that suggests that PET-CTs may not be very sensitive or specific now, any longer. Previous studies had shown high sensitivity and specificity for SUVs over 10, 91% sensitivity and 95% specificity, for that being Richter's transformation. But now it looks like that those numbers after a failure of tyrosine kinase inhibitors may be very radically altered. And in their phase 2 study with venetoclax in patients who were previously treated with ibrutinib and idelalisib, what they ended up doing, they wanted to take out all the Richter's transformed patients. And so they did PET-CT scans on all 167 patients, and half of those patients had lymph nodes with SUVs in the 5 to 10 range, and 25% or 15% of those patients had SUVs greater than 10. They went and biopsied all these nodes, and to surprise that only 8 of the 35 biopsies actually showed Richter's transformation. So now the sensitivity based on their study is 26% with a drop in the specificity, and the positive predictive value has also dropped dramatically. So this new disease that we're getting from treatment with these new targeted therapies is much more aggressive. Complex cytogenetics, you saw that has really impacted the early relapses on these new targeted therapies. The first described by Thompson at MD Anderson here on the left panel, excuse me, on the right panel, and then from Susan O'Brien's 5-year update on the right. But you can see that progression-free survival and overall survival are both dramatically decreased with complex karyotype. So what about venetoclax? Looking at patients who have progressed on venetoclax, what are the factors that are involved there? And just to look here in panel A, Richter's transformation does occur early, and Hodgkin's lymphoma is something you have to be looking for in those patients. And the patients will continue to progress on venetoclax in high-risk patients. And complex karyotype, again, plays an important role. If you can look on panel D, that the complex karyotype there is greatly decreased the progression-free survival of those patients as well. So it looks like that complex karyotype will not only impact early relapse on ibrutinib, but will also impact the length of response on venetoclax trials. So I think one of the studies that really sets some insights on sequencing of these drugs was just published last year by Anthony Motto. 683 patients from multiple centers. I think my previous two colleagues were both authors on this paper. And these patients were treated initially with a TKI, ibrutinib or idelalisib. And then 167 of those patients received second-line therapy. And so the results are actually quite telling. If you look at the question of which did better in frontline setting, it appeared that ibrutinib tended to do better as the first TKI versus idelalisib in frontline from a progression-free standpoint, and also from relapse refractory standpoint. And in the bottom panels, excuse me, you see the effect of the 17p deletion clearly impacted both, but the patients on ibrutinib tended to do better than the patients that received idelalisib. And complex cytogenetics equally did the same thing. So if one looked at now what is the best second-line treatment for the patients, in panel A, the bottom line is chemoimmunotherapy with a median progression-free survival of only 5.1 months. And then the second line above that is the alternate TKI. If you were on ibrutinib, you went to idelalisib or idelalisib to ibrutinib. And the top line is venetoclax. And so whether or not the patients actually were intolerant to or actually progressed made a big impact on the outcomes of the patients as well. So looking at that study, over half the patients that came off the initial TKI did do that because of toxicity as opposed to progression. And so the question still remains is what do you do for the patients that progress? And there's recently published studies from Jones showing that venetoclax is effective in these patients. The majority or half of these patients had 17p deletion, and overall response rates between 60 and 75% were reported with venetoclax. So venetoclax seems to rescue those patients. It also rescues idelalisib progressors, as you can see here from Steve Coutre, just pre-published in Blood, that those patients can be rescued. Now, how long is that effective for? It's about 18 months again. And so progression after ibrutinib or idelalisib with venetoclax is about 18 months. So I'm going to skip over, since we've done most of this. We know that venetoclax is effective and is FDA approved for the patients with 17p deletion. And from Stefan Silgenbauer, you can see here the, again, progression-free survival in the bottom panel, but again point out that that's 18 months. But venetoclax plus rituximab clearly did better than rituximab bendamustine, our previous second-line standard for relapse refractory patients. This hasn't been published, but it was presented as late-breaking abstract at the ASH meeting. So this has led to the latest incarnation of the NCCN guidelines, where relapse refractory therapy, ibrutinib, if you've had chemoimmunotherapy, venetoclax plus rituximab and idelalisib plus rituximab and venetoclax are there. So Jennifer Wyash from Ohio State put together a very nice paper. What do you do with these patients, and what are some alternative mechanisms to try to overcome this resistance? And you can see here in the panel A for ibrutinib, that BTK mutations and PLC gamma mutations are the main causes of those, and provided some potential alternatives for treating these. So we heard already about some of these new promising agents, SYK inhibitors, combination gamma delta PI3 kinase inhibitors, new BTK inhibitors that don't require the cysteine 481 for binding, all appear to be having activity in these high-risk patients, and there's others as well. So what about Richter's in those patients? This was a from David Rossi, a nice review that was published last year, and I'd have everybody take a look at that. And if you look at the response for all these different various chemo regimens, responses vary greatly. But what's common is the progression-free survival that's very short in the right, at the end column there. Excuse me. And patients who do have Richter's transformation, do respond to therapy, need to have a transplant. 3-year progression-free, overall survivals are greatly enhanced in this patient population. You had questions, excuse me, in the previous talk, questions about CAR-T therapies, and let me touch on that briefly. Well, first of all, CAR-T therapies, there's 3 or 4 different constructs that are available now. They are not all the same. They have different response rates. They have different onsets of CRS and also CNS toxicity. And so it's important to understand that they're not all the same. This is the model from initially from David Porter, looking at these new lentivirus transfected T cells. They target the CD19 expressing cells and end up killing them. And this is a highly effective therapy. This was the very first patient. As Dr. Furman mentioned, the first 3 did great. Totally full bone marrow on the right panel, and on the left panel you can see by day 30 there was no measurable CLL. Large lymph nodes go away within 30 days and totally gone by day 90. But the results have been less than robust in follow-up studies. If you look at, I put two different panels here. One looking at CAR-Ts and CLL at the upper panel, and then CAR-T therapies in ALL. And if you look at the CR rates, it's almost 90, 80, 90, 100% CR rate for ALL, and for the CRs in the CLL population range anywhere from 0 to 60%. And overall response rates are somewhere in the 50% range. So achieving a CR is going to lead to cure, and those numbers are not as robust as we had initially hoped. Now, many new clinical trials and ways of augmenting this are now currently in clinical trial, and so I think that there's still a great potential with this therapy. Looking at Cameron Turtles and the Seattle experience with this, you can see that patients' progression-free survival is determined by patients who have the ability to get a CR. And so targeting CR is really the most important aspect of this, and it also impacts the overall survival of these patients. So we need to get better ways of using chimeric antigen receptor therapy in CLL and improve on those clinical trials. It has adverse effects. Cytokine release syndrome is seen in a large majority of patients, and interestingly can be quite delayed in CLL versus ALL, which typically occurs in the first week. Patients at day 21 have had CRS in CLL setting, and neurotoxicity and lifelong hypogammaglobulinemia have also been seen in patients. Now, what we haven't really touched on is the role of transplant, and I just want to point out that in Reiner Storb's analysis of the most sensitive disease to graft versus leukemia effect, CLL and CR was right at the very top of that. And so those patients who go in near or complete remission do not tend to relapse. The early studies with reduced intensity conditioning regimens showed a marked improvement versus myeloablative, where 40% of the patients died of treatment-related mortality. Now it was in the teens. And the more recent published studies with a long-term follow-up, 3 to 5 years. And if you look at overall survival, 70, 50, 63, 51, 55%. And so transplant, I think, is still a very viable option and a curative option. What about 17P patients? From the European database, the 3-year follow-up after transplant showed 52% of the patients living, and the majority of those patients had no evidence of progression. For other things like Notch mutations, SF3B mutations, TP53 mutations, the same thing holds on long-term basis. What's happened with the new targeted therapies and transplant? Data from EBMT shows that number of CLL transplants has dropped by about 40%, just within the first 3 years that the clinical trials started, and that's the last update on data. But I heard from Peter Drager that that's continuing. So timing a transplant, I think, is really a crucial question. All patients we've seen with 17P complex cytogenetics are going to relapse. If you have a 40-year-old who has CLL, you may buy 3 years from ibrutinib, you may buy another two years from venetoclax, and that puts that person at 45. So what are we going to do with those patients? I think that transplant still remains a viable option for these patients. And so it's really important. And transplanting them when they're at optimal disease bulk is really key. We know that more disease means less favorable outcome. This is the current EBMT CLL transplant recommendations. So if patients who fail a BTK inhibitor and or BCL2 inhibitor, those patients have very unfavorable disease and should go to transplant if they're fit, young, and have a suitable donor. So our approach at our center at Mayo, we fully restage these patients, and it's crucial that we know what their cytogenetics are and their CLL fish because clonal evolution occurs in these patients. We do PETs, CTs to rule out Richter's transformation and biopsy sites that with SUVs over 10. We look at BTK and PLC gamma mutation testing and HLA type these patients. If they're found to have high-risk CLL, most of the time we try to put them on clinical trials, but off trial, venetoclax is our standard. If they're transplant eligible, we treat with venetoclax until maximum response, and then have a serious conversation about allogeneic stem cell transplant. For Richter's patients, it's imperative to know if they're clonal or non-clonal, and it's important because if they're non-clonal, you can treat those patients like you treat any diffuse large B-cell lymphoma. Those patients who do have responses tend to, they would take those to transplant because those responses are short-lived. Our current trial is looking at pembrolizumab with ibrutinib or venetoclax in combination. So just a couple of quick pearls on my next to last slide. You gotta continue the ibrutinib even though they're progressing, because if you take them off the ibrutinib, the disease explodes. I mean, literally, I've had patients when we first started doing this in 2 weeks die of progressive CLL. So it's imperative to keep them on them, start them on them. We actually overlap the first month, build up a month of venetoclax with keeping them on ibrutinib, then stop the ibrutinib. For fit younger patients, we HLA type them early if they're complex, even at the time we start ibrutinib, and identify potential donors. For the Richter's patients, it's important to biopsy and not rely just on PET scans. And then debulking patients is key. So my last conclusions, high-risk CLL, those patients with 17p deletion and complex cytogenetics will all progress on these new targeted therapies. A clinical trial of venetoclax is the best option for the progression off of BTK inhibitors. And complex cytogenetics also impacts, you got to remember that it impacts the duration of the progression-free survival. These novel agents are promising, but we need more clinical trials. And remember, stem cell transplant is still the only curative option, but debulking the patients with something improves the outcomes. So with that, thank you very much.